kind of secured active adult, retirement communities, it's really a very, very small percentage of what the overall housing picture is. Most of these folks are living in conventional housing in conventional suburban or traditional neighborhoods, just like everyone else. Here's some more numbers. I think the real takeaway here is that single-family homeowner is still the predominant number, but there is some growth in multifamily rental and multifamily condo. So when we think about sort of, what are the needs, realizing that kind of the age-restricted community is really an extraordinarily small part of the overall sector, it really just comes down to a lot of the things that we talk about in the planning community about just how you make highly functional mixed-use places that have access to basic daily needs, are highly walkable with calm traffic. But just to realize that there's going to be a higher and higher percentage of folks with diminished mobility skills, similar in some ways to that of a child. So I go back to that grandparent-grandchild sort of theme. All of those rules that we've all learned in school and in our career are going to come home to bear in a much more profound way over the next 20 years. Here's an example. This is actually close to where I grew up in Columbus, Ohio. I think this is a great example of an existing community that places a remarkable variety of services within a relatively small area. If you look at the half-mile radius in red, you see a significant park in the middle. You see a neighborhood shopping center right there off Reading Road in the middle. There's a regional mall a little bit to the north. There's a couple of different schools. There's a couple of different churches. There's a senior wellness facility that's part of the Northam Road complex. We just don't build enough of this kind of mixture anymore, and we really need to focus on it, particularly in new development. Here's some of the activities that you see there. So you're seeing everything from Huffman's Market and the Tremont Pharmacy to the senior wellness in the lower right, places that are bikeable, places where you've got the corner cafe and that type of thing. The challenge is, we've built an awful lot of this, and this just becomes harder and harder for folks to manage over time. We're seeing a lot more trend, at least here in Florida, but I've seen it in other parts of the country, of the granny flat, accessory unit type of development. We're even seeing a lot of what you see here. This is actually a reparcelization in the traditional area of Orlando that actually creates an entirely separate unit off the back of the house where the grandparents live. So basically, they have their own unit. It's a ground floor unit. There's a loft on the second floor that's mostly used for storage. But this becomes a tandem lot parcelization, and it's a fully functional home in the back of the property. Also, sort of in the urban environment, I know many of you are just familiar with sort of the fundamentals of the benefits of mixed housing and mixed price points. And again, this idea that folks fundamentally would prefer to stay in their home, or if not their home, stay in their community. Mixed-use places provide the best opportunity to do that. And that can happen in kind of traditional neighborhoods where you look at the fabric in this image, and you think about sort of where those neighborhoods come together in corridors that have the basic services that people need. This is actually another road diet example. This is in College Park, where again, sort of the nexus between calmed traffic, creating a better Main Street retailing environment for the merchants, and then setting up for mixed-use infill development, all kind of adds up to a more livable place that actually is much more suitable for people, again, whether it's a child or whether it's a senior. We work in some suburban areas, and Mimi mentioned Charlotte County earlier in the slideshow as a place in Florida that has a very, very high percentage of folks over 55. We see a lot of development like this in Charlotte County, where this image on the top, Chelsea House, is a retirement community, but the infrastructure in that area is so limited that it's virtually impossible for the folks that live here to access what is actually a wide variety of available services. There's a nearby grocery store. There's actually 2 small community hospitals. There's a number of doctor's offices that are associated with those hospitals. there's a library or a community center, various other things. But in most cases, it's extremely difficult to even get around and access those things because of the form. And so what we're doing is we're going in and actually helping them build a walkable infrastructure, in some cases creating new streets, in some cases creating new mobility services, whether those are bus circulators or what have you, to help people actually get around and better manage a pretty unlivable environment right now. In more urbanized areas, we're definitely seeing a trend towards the development of the mixed-use medical district as an economic development tool, but also as a setting for all manner of new forms of housing, and then of course the various medical and non-medical services that go with that type of development. And we've looked at precedents in Baltimore and Seattle and Boston for these types of things. When we think about congregate living facilities in the urban environment, and this is in Orlando, I think what's really critical that I didn't fully appreciate until I started researching this is actually how much activity goes on between these facilities and the nearby churches, the library, and various other senior centers and retail opportunities. It's very important that these kind of programs to actually help people get around, that these things exist, because the function of going to church or going to the library or going somewhere to volunteer is really what keeps a lot of these people active. Another community forum that I'm sure many of you are familiar with is sort of the TND, traditional neighborhood design. This has a lot of benefits. It's a great model to accommodate your goals of mixed use and mixed price point with a lot of access to services. So I think this model is going to become more and more relevant over time. This is Baldwin Park. This is also in Orlando. What you see is just a lot of different price points of housing, a lot of different types of housing, and then great access to services within a walkable environment. This is the town center. There's a grocery store. There's community centers and so forth. And it is relatively seamlessly tied into the Orlando street grid. Now, when you compare something like Baldwin Park to sort of the age-restricted suburban community, I had a chance to do some interviews with a number of developers of these kinds of facilities, and surprisingly, they were remarkably frank about the fact that, that you see the quote in the middle, you know, we don't really address in-home activity services, healthcare. We just assume that as folks age, the market will address people's in-home healthcare needs. It was actually a little stunning to hear someone just come right out and say, you know, that they realize they're not really building something that addresses the real material needs of people over 65 who generally think they're 10 years younger than they are. And then the other quote that this gentleman made that was interesting, he said, you know, the only developer out there that really has the buying power to really try to provide those services is the Villages. The Villages is a project that some of you not in Florida may not be familiar with. This is a huge land development north of Orlando, south of Gainesville. It has about 73,000 residents. And they have specifically designed this to be a very unique environment to provide specific activities, recreation, shopping, retail, to specifically serve this demographic with special solutions for security, transportation access, activities. I would definitely Google the Villages and see what comes up. It's actually a beautiful environment. It's made to look like a small town. You can see the image in the lower right. Golf carts definitely rule. There's a little bit of a critique about the Villages, though, that, you know, are they really providing services for folks that are having diminished skills, or is it folks that really are still in excellent health, excellent mobility? There are a number of facilities nearby that address the needs of people who are starting to go through some sort of health condition. But the Villages itself is basically set up to be fairly active. So I'm not sure that it's the perfect solution for folks that are in a more diminished situation. However, as you can see, these facilities are actually right nearby. So I think it's a very interesting model for people to study. The other thing about the villages that's very interesting is they realized early in the game that if they were going to deliver an excellent experience and an excellent level of service for the folks that are living there, they were going to need a very, very high-end set of service providers. And the only way to recruit a very, very high-end set of service providers is going to be to develop some very, very high-end schools and a very high-end sense of community so that people actually would want to live near the villages in order to use that as an employment opportunity. So the villages region has got excellent healthcare and educational facilities for the families and kids that are essentially supporting the services that go on in that community. I'm almost done. I think there's just a couple of more things I wanted to share. This is another concept of community, and it's really a virtual concept of community. This is the Beacon Hill Village. This is a model in Boston, and it's really it's a nonprofit grassroots, essentially a concierge service, where for a relatively small annual fee, you see at the top about less than $1,000. They will arrange for you all sorts of in-home services, rides, activities, affinity or activity groups, gardening, grocery shopping. It's a way for people to meet people in a traditional environment as opposed to a created environment like the villages. This is a way to access that social activity and interaction and physical services. It's sort of a concierge level, which I think is actually very interesting. You still have to pay for the services. You may have to still pay for a ride, but the concierge service will screen drivers and require certain qualifications of them and then provide certain discounts to the people who are part of the Beacon Hill Village program, which I think is advantageous to everyone. Here's kind of one more little anecdote on sort of the seniors and sort of their level of activity. This is a couple that I know personally. They're both in their 70s. They're highly active, just as we said at the beginning. They live in a mixed-use development, which they live a couple of stories above a super target. They're right down the street from a Jason's Deli. They've got extra bedrooms where their grandkids can come in. They've got access to all kinds of services in the development that they live in. And they've got their retirement plan figured out. They're going to move to Spokane, Washington, which they've visited 12 times. It's an area here where, again, you can see the proximity of things. The husband is actually a pastor, and this is the church that he could provide some service out of. So I think this idea of relocating, to the extent that folks do relocate, they're looking for livable cities like Portland, Oregon, Boston, etc. So I think to kind of wrap up, just some thoughts about kind of this senior generation. It really starts, your ability to live a long and healthy life with a high quality of life really starts with how you grow up and where you are as a child and the kind of habits that you develop. This couple here, certainly you can change your life midstream, but this kind of fitness and activity at this age, probably traces back to when they were adults and even when they were kids, and the kind of habits that they adopted and the livability of their community and their access to opportunities to be healthy, and the kind of cities that we make or the communities that we make where we think maybe about a high standard of living, do we all have the right car, but really are we creating a place that has the kind of quality of life that promotes livability and promotes a healthy lifestyle that allows people to remain active well past age 65. So that it's kind of the social interaction and joy of being retired and all the opportunities that affords you, that people can take maximum advantage of that. So that's really the conclusion of my talk. It's really about choice, flexibility, having mixed generations within your developments or within your city, thinking about principles of smart growth, which are highly applicable, and then thinking about things you can do as a planner to actually promote and reward types of development that will actually serve this incredibly growing group of people within the country. That's it. I'm going to turn it over to Doug Beach. Thank you.
All right, my name's Doug Beach, and I am the Executive Director of the Volusia County Council on Aging. I apologize for the format. Some of these things have been reformatted on my computer, or by the computer, so it doesn't look quite right. As an economist, one of the things that's particularly interesting with Pete's slides is that many economists, particularly economists looking at urban sprawl, suggest that part of our problem is the fact that we've built too many highways. And if you go ahead and look what's happened with populations, they've moved out of urban centers where actually they were walkable. They did have access to activities, to grocery stores and the like, and we've moved into a completely different era, particularly with this baby boomer population. This slide is my introduction to aging, and many of you probably are too young to remember this, but this is the old people's slide. I'm fine with this. This is the old people's home in Licking County, Ohio, where I grew up. This, we went down there, I was probably in grade school, and we went down there to sing, and as you can see, the bottom is all boarded up. And we went in there, the seniors were disheveled, they were trying to touch us, and I remember it being one of the more terrifying experiences I had up to that point in my life. But these were county homes. They were working farms, most of them. Seniors who didn't have family and were too poor to take care of themselves would go to these county homes. They would work on these farms until they weren't able to, and essentially they'd go to bed to die. Remember that in the 50s and 60s, the poverty rate in the senior population was 43%, compared to now where it's less than 10. So we had the advent of the Older Americans Act, which creates programs like Meals on Wheels. We had the advent of Medicare, Medicaid, which provides for services in nursing homes, and the senior plight, as I said, has gone from a 43% poverty level to the point where we think of, particularly here in Florida, as seniors as our secret economic weapon. A 1999 study by local economist Hank Fishkind estimates the retirement industry is Florida's second largest economic sector. The average Florida retiree contributes nearly $2,000 more in taxes than they cost. Most of residential housing is owned by people 60 plus, and for those of you that are in the political realm as I am, seniors in the last gubernatorial election were 31% of the registered voters, but over 40% of the people who voted. So nearly 1 in 2 were 60 plus. So what's the problem? Well, the simple problem, as all of you know, and these statistics vary, somewhere between 76 and 78 million baby boomers began to retire in 2008. Pressures on Social Security, pressures on Medicare, pressures on Medicaid. Some people have called this an aging tsunami. As for me, I think of it as an opportunity to do some things a little differently. 2004 issue of Roll Call, and Roll Call is one of the rags on Capitol Hill, suggests that, and these statistics are a little bit dated, but suggests that we're looking at a $72 trillion unfunded mandate. Of that, $62 trillion due to increases in Medicare with the aging baby boomers, and over $10 trillion due to Social Security. So when we look at the whole issue, particularly in Florida, we look at Florida communities, and the first part, or the first car of our train, other than the engine, of course, is an aging population. Again, we think of it as potential to do the right thing and help the economy rather than create a train wreck. This goes a little bit at some of the slides that Pete and Mimi showed us. What we expect here in Florida, actually this is nationwide, that the senior population is essentially going to double between now and 2030. The largest or the fastest growing age cohort right now is the 85 plus population, and we know a couple things about the 85 plus population. First of all, somewhere between 40 and 50% of those folks are going to need some help to stay in their homes. And the second thing we know is that somewhere between 35 and 45% of folks 85 plus are going to have dementia. In Florida, it's even more exaggerated. What we're showing here is that we expect the population to increase 27% between now and 2030, with 66% of that growth from the 65-plus population. There are some folks here in Florida that have talked about decreasing the percentage of seniors, getting more young people involved, having industries that will attract more young people. But I would suggest when you look at this slide that seniors are the past, present, and future of Florida. The second car on the train, of course, is scarce funds. And being an economist, I have to show you some of these awful slides, but trying to get a little feel for what exactly is going on. These slides, again, are just a little bit dated, but I wanted to use some statistics that were before the Great Recession that we are in right now, and I think that they're a little bit more applicable and give you a better feeling as to where we're going. If you look at that final column, that fifth column, we're looking at entitlements as a percentage of total spending in the United States, and the fifth column looks at percentage of total mandatory spending. You'll see that the top 10 entitlements consume 90% of entitlement spending. If you go to column 3, which starts with percent of federal outlays in fiscal year 2001, you'll see that if you add up that whole column, you'll see that entitlements account for nearly 54%, a little over 54% of total spending in the United States. Now, why is this so bad? This slide goes into a little bit, and what we're trying to do is see what happens when we compare growth in entitlement spending to growth in GDP, gross domestic product. Couple of slides, a couple of columns that are of particular interest. Column 2 shows overall entitlement spending has increased well above the growth of GDP over the last 40 years, 2.8% for GDP, which is the top row there, compared to 4.2%, 4.19% for entitlements. If you go to column 5, looking strictly at 1975 to 2000, you'll see that GDP has grown roughly 2.6%. Entitlements have grown at 2.6%. So growing at a similar rate. Of course, this is before the baby boomers retire. But if you look at Medicaid, Medicaid's grown at nearly 7%, and Medicare has grown at 6.5%. So two of the big drivers when we look at government debt is Medicaid and Medicare. Let's bring this home even a little bit more. What this slide, and it's a slide about Florida, comes out March 2009. And what this slide shows is that in the state of Florida, the blind and disabled, seniors blind and disabled, again on the left, are about 24% of the Medicaid population, 24% of the Medicaid population. We have 24% of the Medicaid population driving, what is that, 63% of the costs. So anytime we look at Medicaid reform, you can't look past the senior blind and disabled population. Particularly seniors are 9%, driving 22% of the cost. Blind disabled are 15%, driving 41% of the cost. As Mimi has made sure that I mentioned to you, this comes down to the local level as well. Local county organizations are responsible for some Medicaid hospital costs, and in Orange County, Medicaid expenses for Orange County have gone up from 5.7, I think that's million in 2002 to over 13 million in 2010. Medicaid nursing home costs have gone up from, this is the county's share, have gone up from 1.1 million in 2002 to 1.5 million. So these things are increasing at an increasing rate. And then the last thing we like to talk about is the dependency ratio. This slide shows what's happened over the last 50, 60 years. Dependency ratio in the 1950s, there were roughly 16.1 workers to each retiree. Actually, this is just retirees. We're not talking about kids when we talk about dependency here. But it's gone from 16.1 to 1 to, in 2000, is 3.4 workers to 1 retiree. In 2020, it's going to be 2.6 workers to 1 retiree, and in 2030, 2.2 workers to 1 retiree. And what exactly does that mean? Well, this is something I just threw together looking at the average monthly benefit from Social Security, the average wage in 2003, and the average contribution per wage earner in 2003. And as you can see, when we have these different ratios, we go from a positive situation in 2020 with 2.6 workers per beneficiary to strongly negative when we go to 2.0 workers per beneficiary. So the train wreck's complete. When we look at riding the train, I want to talk about 3 things particularly. A little bit about politics, a little bit about economic growth, and a little bit about reducing spending and hopefully increase tax revenues. Now this is very, very hard to look at, but we talked about it a little bit earlier. What you see here, and this is for the U.S. as a whole, that older adults 65 plus constitute about 12.2% of the population. Excuse me, 12.2% of registered voters. Yet in the 2002 election, they were nearly 23% of the folks who voted. So we've got 12.2% of the registered voters and representing 23% of the people who voted. So if people really need and want to get involved in these activities to understand how politicians think. As I said, in the 2006 gubernatorial election, seniors accounted for 31% of the registered voters, but nearly 44% of the people who voted, so 1 in 2. Thinking about this further, clearly any change in entitlement programs, it would be pretty hard given this huge voting block. All right, now this is a whole bunch of squiggly lines which make very little sense. But what I'll say is that if you look at the baseline, and this is what the Congressional Budget Office looks at, they assume a 2% growth rate, and they assume that seniors in the future are going to act like seniors today. Now, Pete and Mimi's slides clearly suggest that baby boomers haven't acted like anything in their whole experience from birth. Why would they start acting like anything as they go into the next step? And so what I suggest here is possibly looking at that bottom pink line. That bottom pink line assumes a growth rate that's more typical of what we've seen in the last 30 or 40 years. Assumes a growth rate closer to 3% compared to 2% with the MA baseline as the Congressional Budget Office uses. It also assumes that seniors aren't going to be active, that seniors are going to end up in nursing homes. And so instead of having these programs, Medicare, Medicaid, and Social Security at 13.5% of GDP, it's actually closer to 9. Clearly not where we want to be, but not as bad as the doomsayers will tell you that it is. Let's skip this slide. What this is a slide that Mimi's provided, and what we're essentially looking at here is public health implications of a number of things: lack of geriatricians, smaller worker to retiree issues, things that we've gone over here, employee caregiver issues, which I'll talk a little bit about, depression and mental health, which we'll get into. And so there are a whole bunch of issues that are impacting seniors on a daily basis. Moreover, when we look at growth in assistive technologies, home health care innovations, long-term care options, I really think that that potential train wreck is actually a potential for us to do things in different ways than we've ever done before and move the economy forward rather than backward. So what am I talking about? Suggestions come from the World Health Organization suggesting lifelong learning to increase the possibilities for older adults finding employment. This Great Recession has really hit the senior population hard, and you see a lot more seniors staying in the workplace for a longer period of time, which at the end will benefit Social Security, Medicare, and Medicaid. Promoting income security policies, access to adequate health care, early intervention and prevention, and of course pension policies, which will allow these seniors to age in place. All right. This slide is an interesting slide in the sense that We've all heard, particularly long-term care insurance salesmen, say that over 50% of seniors are going to end up in a nursing home at some point in their life. Now, the operative term is at some point in their life, and what this slide shows is that for Florida, we have roughly 2.1% of seniors in nursing homes for extended period of stay and 1.9% in assisted living facilities. So less than 5% are in institutional care. The rest, 90%, are what we call well elders, and they're in the community. And what we know is generally those nursing home stays are associated with a rehab stay from a hospital, a Medicare rehab stay. What we want to do, and what we know, is that if we can increase the percentage of seniors, well elders, from 89.1% in this slide to 90.1%, we can decrease Medicaid costs in the state of Florida somewhere between $500 and $900 million. 1% increase in the percentage of well elders will decrease Medicaid costs somewhere between $500 and $900 million. When you have a $3.2 billion deficit in your state budget, decreasing Medicaid costs by nearly $1 billion, of course, is the right way to go. So, riding the train, integrating medical and social services. The four illnesses that we think about, particularly with seniors, are hips, heart, depression, diabetes. Pete and Mimi both have talked about hip fractures. 95% of hip fractures among adults age 65 and older are caused by falls. Every 18 seconds, an older adult will fall in the United States. Heart disease is the #1 killer of women in the United States, yet most of the protocols used to treat heart disease in the United States are based upon white males in their 50s, 60s, and 70s. So again, the whole idea of figuring out ways to use social services to help with a couple of these illnesses. The other two illnesses that we particularly are worried about is diabetes. 23% increase in diabetes between 1990, mid-1990s and mid-2000s. Many of these folks are elderly, many of it related to weight. And then the last thing is depression. 20% of older adults are depressed, 50% of older adults in nursing homes are depressed. I know many physicians think that depression is a normal part of aging. It just isn't. And how we can treat depression to keep people involved in the community is essential to the things that we're talking about. This slide is one of Mimi's slides, and we kind of snuck it in there at the last minute. But what we're talking about primarily with these illnesses is increasing the period of time when seniors are well, decreasing the period of time when they're sick. How are we going to do this? Well, the first thing we want to talk about is physical activity. Hips, heart, depression, diabetes, we know that exercise is a positive on each one of those illnesses. Again, hips, heart, depression, diabetes. So we're thinking, first of all, about exercise, getting people up and moving. And we're thinking, secondly, about going to your doctor age-appropriate number of times per year. I like to use an analogy about my dad. Before Dad passed, when I was growing up, we blew up one truck, 2 cars, 2 tractors, and Mom's blown up another car since then. And so the question always was, what's more important, a $35 oil change or a $3,500 engine? Same thing with human beings in most ways. If we can get things through early intervention, we can often, or prevention, we can often head it off at the door, so to speak, head it off at the pass, and make seniors, as well as anybody, let them have a happier and healthier life for a longer period of time. The second part of the activities that we're talking about to fight hips, heart, depression, and diabetes are intellectual activities. There were a series of tests done by a guy by the name of Snowden on some nuns in Kentucky and Tennessee, carried out in the 1970s. And what Snowden was able to show is that for those young nuns that were intellectually active during their lifetime, even though they had Alzheimer's disease by brain biopsy showing that they had Alzheimer's disease, even though they had Alzheimer's disease when they died, they didn't show the symptoms when they were living. For those nuns that weren't intellectually active during their lifetime, they showed all the symptoms of full-blown Alzheimer's disease. So what we know is that if we can keep people intellectually active, doing different things than they are used to, we can either do an end run around dementia or at least slow it down. The last thing that we talk about in combating hips, heart, depression, and diabetes is social activity. In Putnam's book, Bowling Alone, which I'm sure many of you have read, he suggests that social isolationism is as difficult on a senior's health as smoking. We also know that the frequent flyers in nursing homes and emergency rooms tend to be socially isolated seniors. And as I suggested earlier, 20% of seniors are depressed, 50% of seniors in nursing homes are depressed. The suicide rate in the senior population in Florida, and I think it bears out nationwide, depending on what state you are, is either number 1 or number 2 suicide rate of any age cohort in your various states. So again, hips, heart, depression, diabetes, and physical, intellectual, and social activities. So what are we talking about with respect to the types of, these are examples of just some programs that help us get there. This is a respite program based upon a Brookdale model in, that we applied here in Volusia County. And what we're able to do is that if we can keep caregivers helping their loved ones for a longer period of time, the statistics suggest that United States as a whole, it costs over over $650 billion a year to replicate what caregivers do. Yet caregivers tend to be under tremendous pressure, and I like to talk about the three-legged stool of caregiving. First leg of the stool is the out-of-state sister-in-law that calls mom every day to make sure she's properly agitated. The second leg of the stool is, the aging expert. When you ask them for help to take care of mom, the person says, well, it's your mother's journey and you're just along for the ride, and you say, but it's in my house. And then third leg of the stool is when mom comes in once or twice a week, 2 or 3 a.m. and says she absolutely needs to go to the emergency room, and you get her to the doctor the next morning. She's good enough to go to the doctor the next morning. The doctor asks her how she is, and she says she's fine, and so then the doctor thinks you're the one with dementia. So the bottom line is, how can we keep these caregivers involved in their with their loved ones for a longer period of time? And of course, respite programs tend to be the answer. Senior centers are the focal point for many of the activities we talk about. Senior centers provide a reason for seniors to get up in the morning. They provide that necessary socialization, can provide the necessary physical activities, and can provide the necessary intellectual activities. And then the key for almost everything we talk about, and Pete went into it quite extensively, is transportation. How do we get people connected with their communities? I know that many of you remember the movie Cocoon. I would suggest that you go back and look at that movie, because everybody thinks that movie was all about a bunch of pods coming down to some remote county in western Florida and Don Amici doing backflips off of a backboard. But the fundamental issue in that community was the fact that the guy that owned the car was going blind, and they were all afraid that they wouldn't be connected to the community anymore. So transportation is often the biggest problem that we need to solve, but the most important problem in trying to keep seniors socially, intellectually, and physically active. And that's my presentation.
Okay, wonderful. Mimi, are we ready for Q&A?
Yes, we're ready for questions and answers.
Okay, and I'll be able to assist with that, Mimi.
Awesome.
Okay, so the first question comes from Michael. He points out that all of the photos showed in the different presentations, they show nice flat communities. Florida, Central Ohio, that sort of thing. What about communities that have large changes in elevation? Seniors walking or biking is not really possible. Many living situations are isolated, even though services may be close by. How do you deal with those issues of elevation?
I guess I'll jump in and start with that. This is Pete. I think, and particularly, you know, a lot of those areas with a lot of elevation also correspond to snow and ice and all the things that come with that. I think it has to do, in my mind, maybe with a couple of things. One is, you know, when possible, erring on the side towards developments that allow for greater physical proximity, just so that the fundamental difference between uses is less. Taking as much care as you can towards following all of the ADA sort of basics in terms of ramps and grade change and having non-skid surfaces and all those types of things. But also, I think in those areas, if it really is more difficult terrain to traverse, you really are leaning on developing systems that can provide bus transit service or circulator, or like I mentioned with the Beacon Hill program in Boston, the sort of concierge access to rides and those types of things. So I think it becomes more of a community transportation function that can either be privately funded or can be funded through some sort of a medical, I mentioned sort of the medical district model, where you can get enough concentration of uses and density in a certain area, you can actually start to create programs that can be fairly specialized.
There's a program that's actually here in Orlando, started in Portland, Maine. This is Doug Beach, called the Independent Transportation Network, and it's an arm-in-arm program, and it's volunteer-based, where people actually can pay for their loved ones to get the transportation. And at the end of the day, they go ahead and they come to the senior's door and help them get in the car and help them go to medical appointments or shopping appointments or whatever they need to be. But there's increasing number of transportation options. Again, this one started in Portland, Maine. All over the United States, we have a program down here in Florida called Volunteers in Motion, which is out of Brevard County, where they let volunteers drive Brevard County vehicles to take visitors for transportation services. Transportation is extremely important. One of the things that we always try to do is figure out ways to integrate churches, to the extent possible, school systems, in trying to look at the transportation issue, because that's the 1,000-pound gorilla or elephant or whatever you want to say that's always in the room lurking at any type of senior services we do.
Yeah, let me just jump in one more thought on the church question. The congregate care facilities that I visited, on a Sunday or on a weekend, and then usually there's a special night during the week, often it's a Wednesday night, when you have a small bus vehicle that within a very short distance can hit 5 or 6 congregate care facilities in 15 or 20 minutes, because you're in a little bit more integrated sort of traditional urban area. And conversely, when you've got a congregate care facility that can send a bus out to a grocery store, a library, a church, and a senior center within a very short drive, that's just highly functional and highly doable from a financial perspective. When things get just exponentially spread out, then the ability to provide those services becomes extremely difficult, whether it's a public service or a private entity providing the function.
Thank you. The next question is from Richard. He wants to know, how have you responded when asked the question, do you think universal design could be counterproductive by making things too convenient for the elderly, whereas using stairs, bending up and down, walking longer distances, or physical exercises indirectly forcing elderly to exercise? I'm assuming a balance of both may be necessary. So what are your thoughts?
Yeah, excellent question, and actually, as I've been thinking about this stuff over the last couple of months, that same thought has come into my mind. As an example, my father worked for about 35 years at Ohio State University, and he worked on the 4th floor, and he took the stairs to and from every day of his life. And I'm a big believer in take the stairs, and those types of thoughts about, just daily exercise and everything. What I found is, particularly my parents now, and they're considering buying a second home. They actually live in a ranch home now. They definitely want a one-level home going forward, because they've watched their parents go from 65 to 75 to 85, and the functional reality is you do get to a point where the stairs just become impossible. There is a universal design principle, and it's in the National Home Builders Association, that if you have a multi-level house where maybe the bedrooms are above, that you have a room on the ground floor that's easily convertible to a bedroom, and that's a great retrofit solution. The other comment I would make is it's incredible to me, a lot of the older homes I go into, and I actually own an older home, just how narrow some of the hallways are, how cramped and difficult some of the bathrooms are. And so I think the concept of the universal design is that if we would just look at some very simple parameters, sometimes it's just an additional 6 inches here, or orienting a toilet or orienting a sink, in a different way, just makes it so much easier to circumnavigate. And those things, I think, pay material dividends down the line. And my final thought on it is I know a lot of folks that are sort of my age, mid-40s, that may be doing some sort of modification to their home. In some cases, you might be redoing your kitchen, for instance. And it's amazing to me, actually, some of the kitchen remodels, for instance, or bathroom remodels that I see done that fundamentally gut the room, and yet at the end, I know that there's a spot in that design that is, 8 inches too tight, or is going to be a difficult scenario down the line, and it wouldn't really have been a big cost differential to think a little bit more subtly about how we deal with sinks or how we deal with clear passable areas.
And if I can just jump in, we keep talking about falls prevention, and the reality is if you fall, about 70% of the people that fall and break their hip, they have their quality of life significantly impacted. 50% will use a cane, 20% will likely die within the year. What universal design does is allow somebody who's had a traumatic event be able to stay in their home. My mom has a 3-story house. The bedrooms and the shower are on the 3rd floor. If something happens and she does fall, she can't live there anymore. And so she can no longer live in the house that is comfortable for her. And that situation happens very, very quickly, so it's not something that you can plan for. You're automatically suddenly faced with, oh my goodness, what can I do with mom?
Well, but the fundamental question is an interesting one, because universal design does not prevent you from doing what's in your best self-interest. And clearly, if you look at hips, heart, depression, and diabetes, the only thing that we know that positively impacts all 4 of those diseases is exercise. So whether you're in a universal design area, or whether you're in a rural area, or wherever you are, you should be out walking every day, jogging every day, yeah. Or if you have gait limitations, in a pool every day, band exercises, people need to get up and get moving.
Next.
Wonderful. Okay. How do we reconcile accessibility requirements and neo-traditional developments where raised foundation and steps leading to an inviting front porch are commonplace? Providing a second side access point with a lot grade and accommodating ramps on a small lots can be very difficult. So what are your ideas for Kenneth on that?
I agree that this is actually a real problem, and as an urban designer, I really like homes and buildings that are off the ground. I always sort of fundamentally feel like that the fundamental reason for having a house is to get off the ground. And so when I see a lot of homes that are sort of slab on grade, it sort of runs counter to that. But I think that nevertheless, it's actually important that we do maybe at least in some portion of our development portfolio within a city, that we actually do look at, slab on grade. And I think that when we're in a TND environment, I think secondary entrances and rear entrances actually typically do set up as being a zero threshold situation. So, if you want to put the money into it, essentially you can have steps on the front and zero threshold on the back where the car comes in, or on the side. But it is a challenge. I mean, I don't have a clean answer for you on that. But it's clear that if the only way to get into the house, or the primary way to get into the house, is with 2 or 3 steps, then from the viewpoint of a senior, it's a more difficult situation, and you know, certainly handrails and all those things help, but it is more difficult.
Right. And that's the point. You know, at a minimum, you need to have handrails
Absolutely.
that are securely tied down either in that concrete or to that house, so people can at least have something to grab on. Often, what you'll see is that the handrails are rickety, and so not only do you fall taking the handrail with you. So at least have those things locked down.
Yeah, I mean, the best ones I've seen have got really substantial kind of wrought iron handrails, and they're connected to a townhome kind of development, and the whole dimension of the step is not very wide, so you might even have handrails on both sides, and that sort of thing. But it is that is a challenge. I don't have a clean answer for that.
Okay. What can land use planners do to assist with the community building aspects for seniors? That's from Natasha.
Well, I think one of the things that, you know, typically one thing that people have problems with is putting in grab bars and things like that. So if there's some way to make many of these things more attractive, that would certainly be helpful. You know, clearly Pete's suggestions early on that you have a design that will not only accommodate people that can get up and around, but what happens if 20, 30 years from now they need either a walker or a wheelchair. So having those types of accommodations, I think, but doing that early in the process rather than waiting to refurbish something when people may not have the money to do it.
I think, just to add a couple of things, I think that you can look at sort of kind of passive kind of policy things that generally promote mixed use types of developments, mixed price point developments, sort of inclusionary zoning, you know, types of practices, into things that start to get a little bit more proactive in terms of providing density bonuses or other essentially incentives for things that actually facilitate either reinvestment in homes to adapt them to a universal condition, or things that can directly benefit someone coming in trying to provide housing that is specifically geared towards seniors, or the ability to be adaptable for seniors.
And I also think that it's important, you know, when you're talking to developers to really talk about some of the different land uses. Commercial or office can include a lot of different things. It can include doctor's offices that have to be close to residential facilities. A little corner store is really, really important. Exercise companies that focus on older adults, the yoga, the tai chi, the qigong, encouraging and dialoguing about business opportunities and uses that can be in close proximity to where seniors might live is really important.
Yeah, I think actually trying to adopt a facilitation sort of attitude as opposed to a regulation attitude for certain key uses that may come into a neighborhood that could be, you know, for instance, if there's again a doctor's office or a dentist or a grocery store, you know, finding ways to actually incent or at least streamline the process for those types of uses that start to build towards a mixed-use environment. Okay.
Well, we're now out of time, so I do have to draw things to a close. I appreciate the questions. A number of those of you who did ask questions, for example, about NORCs and other kinds of aspects, we will be hosting more of these webcasts coming up over the next month, and so I'd encourage you to register for those as an opportunity to learn more about the details of planning for aging. I'd like to thank our speakers today. You all did a wonderful job, and I will follow up via email with Mimi, providing an evaluation of today's event. And for those of you that are leaving the webcast, please remember to fill out your evaluation form on your way out. Thank you all.
Great, thank you. Okay, is she going to stay on the line and talk to us?
No, what I'm going to do is I'm going to go ahead and close out the webcast because everybody's leaving, and I will just communicate by email after the fact, okay? We would like to get a copy of a PDF of the presentation today so that I can post that on the website.
And I will email it to you.
Okay, wonderful. Thank you.
Thank you.